Okay, now we have finished the fate of acetylcholine, so let's go and see what happens to catecholamine or norepinephrine. Again, we will draw the brain, spinal cord, which sends parasympathetic nerves supplying visceral organ, and let's take a heart for an example. Here we are going to draw the sympathetic nervous system, which we are going to discuss, and this is its nerve endings. We have finished studying acetylcholine, so now let's shift to norepinephrine. You already know nerve endings of sympathetic contain norepinephrine, and I have told you before, when signals reach those nerve endings, norepinephrine is released. Then it binds to one of the 5 receptors you know, alpha 1, alpha 2, beta 1, beta 2, and beta 3. You already know that heart contains beta 1, but this is not our concern right now. After norepinephrine is released and performed its function, most of it undergoes a process called reuptake. Let's agree that there is nothing can just stand still without purpose. Either it has a function or it's broken down immediately. So the remainder of norepinephrine after performing its function undergoes a process called reuptake, and this reuptake represents about 80% of the total amount. Let's just draw a better picture of nerve endings. This is nerve ending and this is sympathetic nerve. In this nerve ending, after norepinephrine is released, it's subjected to a process called reuptake for 80% of the total amount. There are 2 levels of this reuptake process. The first level, when it just enters the cytoplasm, after crossing synaptic space, there is certain transporter. This transporter enables norepinephrine to enter the cytoplasm of the cell. Then it's immediately stored into vesicles again, just like it was before. Because cytoplasm of nerve ending contain mitochondria, which has a certain enzyme you know from biochemistry called MAO enzyme or monoamine oxidase enzyme. If norepinephrine remains in cytoplasm and don't hide quickly in those vesicles, this MAO enzyme breaks it immediately. That's why norepinephrine can't remain free in the cytoplasm for long periods of time. However, free norepinephrine can be present inside cytoplasm, but in tiny amounts, because the majority of it must quickly hide from MAO enzyme. So what happens if norepinephrine became stubborn and refused to get inside the cell and remained free in the synaptic space? No one would prevent him, however, someone could actually destroy him. This someone is called COMT enzyme. So norepinephrine acts on its receptor and become consumed. However, the remaining amount must be removed by recycling for 80% of the remaining amount. The other 20% which refuse to enter the vesicles are destroyed by the MAO, and those present in synaptic space are destroyed by COMT. So 20% of the amount is metabolized and 80% of the amount is safely stored inside the vesicles. Again, remember that the 20% fail to be stored in the vesicles are destroyed either by MAO or COMT enzyme. This MAO enzyme has 2 isoenzymes. One of them is called MAO-A, monoamine oxidase A, and the other is called MAO-B, monoamine oxidase B. Both of them are present in central nervous system. MAO-A is present in CNS and nerves in general, and in the brain. It is also present in peripheral nervous system. However, MAO-B is mostly not only, but mostly is present in the brain. So remember, B is for brain, not in peripheral tissue. Both of them, MAO-A and MAO-B, destroy the amount remains from norepinephrine, which couldn't be stored in the vesicles. Those inside the vesicles are safe, but those free in the cytoplasm are destroyed by monoamino oxidase enzyme. And these free in synaptic space are destroyed by COMT enzyme. Now you may wonder why are we studying this part? That's because we are going to study a certain medication in the autonomic nervous system called reserpine. This drug is not commonly used these days. It was essentially used as a treatment for hypertension. If you want to give this drug called reserpine a name befitting its qualities, it would be called the most scandal drug in the book. Why so? Because its mechanism is based on one of the most treacherous actions in history of medicine. So let's see together how this drug works. This drug goes to the vesicles and prevents norepinephrine from entering them. In other words, it allows norepinephrine to be released, perform its function on the receptor, and the remaining part to come back. He let them come back and enter the cytoplasm. However, the scandal prevents them from entering the vesicles, which leads to a slaughter, since this thug here called Mao is waiting for them out in the cytoplasm. And by time as you take this drug reserpine, more and more norepinephrine is destroyed by this enzyme, depleting the body from norepinephrine. And when your body has no epinephrine, sympathetic system ceases to function, so blood pressure is lowered. This drug is not commonly used these days because it leads to what known as medical sympathectomy. And sympathectomy means cutting the sympathetic nerve. It becomes out of action because it no longer has transmitters in it. So, what is the resultant compound of breaking down norepinephrine by monoamine oxidase enzyme and COMT enzyme? Norepinephrine is transformed into two substances. One of them is called metanephrine. The other is called VMA or vanillyl mandelic acid. These are two major metabolites of catecholamine. Remember that catecholamine are amines involving adrenaline, noradrenaline, and others, but it mostly refers to adrenaline and noradrenaline. The result of metabolism of catecholamines are metanephrine and vanillyl mandelic acid. We need to understand this as we have many diseases that can be diagnosed by these two metabolites. So if I may ask you, since these are metabolites of norepinephrine, can you tell me what does increase their level? Or what can raise the level of metanephrine and VMA in blood? And by the way, they can be measured in blood or in urine. Can you tell me what does increase their level? In other words, if I take a sample from your blood and measure their levels and they were raised, what can cause such case? You would tell me, since their levels are high, then my body is releasing much norepinephrine. That's correct. But what are the reasons? The first reason my body is producing so much norepinephrine is stress. Nervous people or people under prolonged stress. You even know from physiology that in nervous people, sympathetic is dominating over parasympathetic system. Can't sleep, can't eat well, and so on. Therefore, his body is releasing much more norepinephrine and catecholamines that are metabolized, raising the level of metanephrine and vanillyl mandelic acid. But what is the normal level of metanephrine and vanillyl mandelic acid? Catecholamines blood level shouldn't exceed 10 nanograms per liter, so each liter of your blood doesn't have more than 10 nanograms of catecholamines. This stress can elevate their level tenfold. So, if you are feeling tense right now, your blood level of catecholamine will reach 100 nanograms per liter, tenfold increase. This is the first reason. Let's shift to the next reason. The second reason behind increased blood level of epinephrine and vinyl mandelic acid is external epinephrine administration as medication, for example by injection. If someone gives you intravenous adrenaline bolus or parenteral adrenaline, the level of epinephrine rises 100-fold. And the third reason, which is rare but also very important, is a tumor. I have told you before that suprarenal gland has single nerve supply only from sympathetic system. And this suprarenal gland situated above the kidney is responsible for releasing adrenaline and noradrenaline. However, it releases adrenaline more than noradrenaline because it has an enzyme that converts norepinephrine into epinephrine. So now, this is the gland responsible for releasing catecholamine or adrenaline. Imagine if a tumor occurs in this gland. These cells that release catecholamine is called chromaffin cells. So if a tumor arises from chromaffin cells, catecholamine blood level increases, and when catecholamine blood level increases, catecholamine metabolites level also increases, this time thousands folds. So stress raises it 10-fold, injection raises it 100-fold, and phenochromocystoma raises it thousands folds. So remember, phenochromocystoma is a tumor arising from suprarenal glands, mostly is unilateral. 90% of cases are unilateral, and 90% of cases are benign, not malignant. Its incidence is 5 per million. From every million human, only 5 experience this tumor. But how can we diagnose this tumor? What do you think? When someone has suprarenal gland tumor releasing high levels of adrenaline and noradrenaline, what do you think of his blood pressure? Of course, it's very high. So when someone suffers from high blood pressure without any apparent reason, and you measure the level of epinephrine or vinyl mandelic acid in plasma or urine and find out they are elevated, then you start to doubt one of the 3 reasons: stress, external medication, or phenochromocystoma. That's why you order a CT scan. This is a picture of a CT scan. This CT scan shows suprarenal gland tumor and proves your diagnosis. So, the 3 reasons behind increased level of norepinephrine or catecholamines are stress, external medication, or the rarest but most dangerous is phenochromocystoma. Let's just clear this board to have some more space. After we have finished this part, let's illustrate some of the exceptions. And remember to leave exceptions for the last. When you are explaining any topic, always start with the common, then progress to the exceptions. So here, what are the exceptions? This is spinal cord, which sends parasympathetic fibers. Let's give this fiber blue color. And this is sympathetic, and I have told you that most organs in your body have dual supply. However, some organs receive single supply, like suprarenal gland that has only sympathetic, sweat glands that has only sympathetic supply, and most of blood vessels have only sympathetic supply. The 3 are suprarenal gland, sweat glands, and most of blood vessels. Don't forget, this was mentioned before. So now I want to tell you that this suprarenal gland receiving sympathetic supply and its nerve endings are expected to have norepinephrine as any other organ supplied by sympathetic system. However, nerve endings here don't have noradrenaline but acetylcholine, and this is one of the exceptions, because although it is supplied by sympathetic system, the chemical transmitter inside it is acetylcholine. So, in this case, the nerve reaching to suprarenal gland is termed sympathetic cholinergic nerve. It is sympathetic nerve, part of sympathetic system, however, its chemical transmitter is acetylcholine. Theoretically, if I give you an injection of acetylcholine, this is impossible of course, but let's imagine if we can, one of its effects inside your body is to act on the receptor on suprarenal gland and releases adrenaline. How strange that adrenaline from suprarenal gland is released by acetylcholine. Same scenario occurs in sweat glands, which receive sympathetic nerve. Its nerve endings are expected to have noradrenaline as transmitter, but no, it also has acetylcholine. Also, little amount of blood vessels, little, not many, are the same as these two, have sympathetic, however cholinergic. So they have sympathetic nerves but are controlled by acetylcholine. Okay, remember, we are pharmacologists, not physiologists, so we need to understand the effect of drugs, not the effect of sympathetic nerve stimulation. And as long as the chemical transmitter that controls something, like here where acetylcholine is responsible for the function of organs, I'm concerned with acetylcholine effects as a drug, not by sympathetic effect on the body. Now I want to tell you about skeletal muscle. Is it autonomic organ? When you move your hand, is it autonomic or voluntary function? Of course, voluntary or motor, not concerned with autonomic nervous system. So, the nerve supplying skeletal muscle is motor nerve, not autonomic nerve. Correct? Indeed we are. However, the chemical transmitter in the nerve ending is also acetylcholine. And when it is released, it acts on a receptor on the muscle. This receptor is like a gate, such as the one I have told you about in the ganglia. In the previous video, I have told you about a gate inside ganglia called nicotinic acetylcholine receptor, which is a gate opens by acetylcholine resulting in sodium ions influx causing depolarization wave and action potential leading to muscle contraction. The gate within the ganglia, which are same as this one in the muscle, called nicotinic acetylcholine receptor, and takes the letter N, short for neuronal. However, the same gate in muscle takes the letter M, short for muscular. So we have two types of nicotinic acetylcholine receptors, one in the ganglia termed neuronal and the other in muscles and termed muscular. These receptors are completely different in both structure and function from receptors inside normal tissue like M1, M2, and M3, which we are going to talk about in the next video. Before we finish this video, I want to tell you about something important. In the 90s, there were bacteria from family called Clostridium which release certain toxin termed neurotoxin because it causes paralysis. This toxin is present in improperly home-canned food. You sometimes hear about people who die after eating expired canned food because canned food is perfect media for anaerobic bacteria that doesn't need oxygen like Clostridium family. This bacteria release certain toxin. If reached nerves, it can cause paralysis throughout the whole body. So how can someone die from this toxin? Because it causes paralysis of respiratory muscles. And that's because this toxin can inhibit the release of acetylcholine from nerve endings. But this toxin specifically inhibits acetylcholine release in the neuromuscular junction in this part of the muscle. That's why it causes paralysis. Now they are using this toxin in cosmetics, however, in very tiny amounts. This toxin that causes inhibition of acetylcholine release and is termed botulinum toxin. Since this toxin can cause paralysis of skeletal muscle, then we can use it in very tiny concentrations for medical purposes. How can we use such toxin in medicine? Imagine if someone is experiencing spasm of certain muscles in his neck. This spasm can be so severe that it can cause terrible pain. So imagine if we locally inject the muscle with tiny concentrations of this toxin. It will cause paralysis of this muscle and relieve the spasm. However, if it was delivered in higher concentration, it can kill the patient. Now, to the interesting part. Don't all people get wrinkles on their face or what's known as frown line on the front of the face that makes one look older? And where do those wrinkles come from? They are result of aging process and overactivity of these muscles. When frontalis muscle and muscles surrounding the eye are overactive, it causes wrinkles that people dislike. How can we do this? We can simply administer botulinum toxin in very tiny concentrations here in the forehead and here around the eye and here around the mouth. This results in controlled paralysis in these muscles. Thus, these muscles become relaxed, and when these muscles are relaxed, wrinkles go away and one can look so much younger. This is what you may know as Botox. So if someone asks you about Botox injection, you now understand how does this medication work. To summarize, Botox is botulinum toxin, which is neurotoxin found in poorly home-canned food. Companies are producing it through genetic engineering. Then it undergo processes of purification, and only tiny concentration is used. About 50 units are injected to the face, can make you look so much younger. And of course, it's very expensive, not because these bacteria growing on rotten food are, but because how this toxin is produced. A single unit of Botox costs around $10, and an average treatment about 50 units can cost about $600, so it's expensive. After we have finished the main bulk of this topic, we are clarifying some more other points. May I ask you, do you think that life is only about sympathetic and parasympathetic? Because many fresh students think all autonomic is about sympathetic or parasympathetic system only. However, there is a third system present in the intestine. Imagine if this were a cross-section in the intestine. Here we have a third division called enteric nervous system, composed of collection of neurons inside Meissner plexus of nerves present inside the intestine. Indeed, intestine receives both sympathetic and parasympathetic. However, if you cut a loop of intestine devoid of these nerves, you notice that this loop still undergoes peristalsis. Where does this peristalsis comes from? This loop has local control system called enteric nervous system. Both sympathetic and parasympathetic are merely regulating it. However, if you cut them both, intestine can still work. You may find an MCQ question asking about the third division of autonomic nervous system. The answer is enteric nervous system. Another fact you need to know, although the system called enteric nervous system and is a third part of autonomic nervous system, nerves controlling this system neither release acetylcholine nor noradrenaline. So, how do these neurons work? They act through other transmitters. Don't you ever think that acetylcholine and norepinephrine are the only transmitters we have? We have uncountable numbers of transmitters such as ATP, purines, angiotensin, histamine, serotonin, substance B, nitric oxide. All of these are transmitters, but they are not specific for sympathetic nor parasympathetic. They are general transmitters. These systems that are similar to enteric nervous system, which doesn't follow sympathetic nor parasympathetic rule, are sometimes called NANC system, short for non-adrenergic, non-cholinergic. But are these transmitters considered primary transmitters? Our primary transmitters are acetylcholine in parasympathetic and noradrenaline in sympathetic. These transmitters are termed co-transmitters. Co means cooperative. So these are cooperative transmitters, not primary transmitters. The basic autonomic control in our body is either by sympathetic or parasympathetic. Many organs have local control system. This local control system is termed NANC system. This NANC system is controlled through transmitters other than acetylcholine and norepinephrine, termed co-transmitters. The last point in this video is the significance of this system. Sometimes this nerve is sympathetic. This means it releases norepinephrine. And this nerve here is parasympathetic, releasing acetylcholine. Those are the primary transmitters. Sometimes there are transmitters in nerve endings, either sympathetic or parasympathetic, other than primary transmitters. There is no nerve ending that has only one transmitter. Surprisingly, any nerve ending has one primary transmitter and others that are co-transmitters, helping the primary transmitter. So, in case of parasympathetic system, the primary transmitter is acetylcholine, and others helping it are co-transmitters. What are these co-transmitters? Here they are: ATP, purines, angiotensins, histamine, serotonin, substance B, nitric oxide, dopamine, and many others. But do these co-transmitters have their own receptors? Yes, they have. However, its function is to regulate the motion of primary transmitters. To summarize, any nerve in your body, either sympathetic or parasympathetic, may have other transmitters than the primary transmitters, called co-transmitters. Their function is to regulate the primary transmitter, and if I have a tissue with no sympathetic or parasympathetic control, is it possible? Yes, and it's called NANC system, such as enteric nervous system in intestine that doesn't have acetylcholine, epinephrine, nor norepinephrine, but is controlled by these co-transmitters. See you in the next video where we will discuss cholinergic receptors in detail, M1, M2, M3, also adrenergic receptors alpha 1, alpha 2, beta 1, beta 2, beta 3, their sites and function. It's going to be our base to understand how drugs work, and then we start pharmacology.